We also suggest that if you're using a maxillary case, you may want to anesthetize the ridge at least 10-15 minutes before to get the volume of the anesthetic dissipated nicely. We then place the template or guide onto the ridge. It will fit very intimate onto the site. If it doesn't, abort the case, and there are several reasons that it might not fit. If perhaps by mistake you put the anchors in too deep, the sleeve would hold up against the tissue, so that would be a problem. In the rarest of occasion, there may be a little resin flash that you can just flick off that would hold the prosthesis off. I have not seen that, but I have heard about it from some other colleagues. So the surgical guide is positioned. This is an occlusal view, and you can see how using these sleeves we'll be able to three-dimensionally precisely place the implant mesial distally with depth and with angulation that's been pre-planned, and a higher power view of that. Now, this is the next important jig. This is the stabilizer jig, or the surgical mouth jig, that will be placed into the inserts of the guides and against the opposing arch. This has several functions. It will dissipate the forces of the guide uniformly against the edentulous ridge. If there's still any residual anesthetic volume, it will help spread that out. And it will also allow the patient to be stable when you're placing the first part of the surgical step, which are the anchor pins. The 3 anchor pins are placed with these stabilizer jigs into position. Sometimes the lab partner makes them, sometimes we make them in our office. In this particular case, it was made by the laboratory partner, and you'll notice that there's a recess to allow for the anchor pin to be placed without any complication or interference. The lower prosthesis for this patient is fit against the underside of the stabilizer jig, and this is then placed into the mouth and secured and stabilized. Again, these cases are usually done just with local anesthetic, and the patients are quite comfortable throughout the procedure. The first step is a 1.5 millimeter twist drill that has a hub at it at the end. You'll drill in and drill out, and that depth is pre-known, and the anchor pins will be then placed 1, 2, and 3. So it drills down to the hub, stop. You pick up an anchor pin from the kit and place it into the site. The kit is well labeled, and it follows the sequence, and you'll see you'll pick up an anchor pin and place it into the site, 1, 2, and 3. At this point, the patient will open up. You'll take out the lower prosthesis, and you'll take out the stabilizer jig material, and you're now ready to work with just the guide. At this point, there's an intimate fit of the guide to the soft tissues, and with the horizontal anchors, it's very, very rigid and stable at this point. However, we recommend the use of a template abutment to further secure it in a more vertical manner, and we'll go over that now. If we're doing a totally edentulous case, we may consider utilizing position 2 and position 5 to get a good maintenance of the space and the stabilization effect. Now we're ready to position it into the site. We use a series of inserts because, as I mentioned previously, the guide sleeves themselves come in 4.3, 5, and 6. So to get the precise positioning of the drills, we use the insert, 2-diameter insert, that will allow for a drill of a 2 diameter to go in a 3-dimensional precise way. This schematic will show actually the steps involved. On the left, we have the guided twist drill 1.5 that will allow the anchors to be placed. There's a very unique soft tissue punch, which is the second or the first drill on the right side, which does several things. It will pierce the soft tissues, it will make a slight countersink, and it has a cutting end at the tip, which will correspond to the 2 millimeter twist drill, which is the first step of the drilling protocol. In pink, you can see the area where the depth will go through the height of the anchoring guides. This would next show a 8 millimeter long implant, followed by a 13 millimeter implant in the magenta color. Those are the 3.5 diameter implant sites. Why would there be an 8 and a 13? It's to demonstrate the possibility, if you're dealing in a posterior region where space is of a limited amount, you may have to use a shorter drill first. Then we take that out, and then we position the drill into the osteotomy, then hook up the handpiece and continue on. You'll then notice a yellow. For this patient, we're going to do a 4.3 implant, or the yellow. We have the yellow drill. The yellow drill is followed by two other drills. A dense bone drill. We mentioned earlier that sometimes the bone is dense. We'll want to do a dense bone drill, or the use of a tap, which is done at slow speed. If the bone is soft, we'll use a undersized technique, or if it's medium bone quality, we'll just use the yellow to place a 4.3 implant. On the right, you'll notice a mount and an implant. The mount is similar to mounts that we use for the conventional implants. However, they're longer to accommodate the precision through the guide sleeves. So it takes up the height of the guide sleeve and allows for us to three-dimensionally position the implants into place. You'll also notice some dimples on the aspect. You can deliberately position these dimples to the facial, and that would allow for the internal mechanisms to be in an ideal position. If we're using a teeth in an hour protocol and using the clamping or guided abutments, it doesn't really matter. However, for some cases that we're going to upgrade in the future to conventional crown and bridge prosthesis, it would be ideal to position the dots in the right spot to allow for the internal trilobes to be ideally positioned. Again, the tissue punch is a critical step. I have unfortunately seen some colleagues forget about this step or deliberately not use this step, but it's a very useful aspect of the case. It will precisely go through the guide and position the soft tissue hole and puncture into the crest of the bone in a very precise way, allowing for the second drill or the 2-millimeter drill to go through a pre-punctured site. We then go through the steps as mentioned, and we position in number 2 and number 5 the first two implants. We then use a unique feature of this system, the template abutment. The template abutment is also a clamping abutment to the top of the implant. It also has a slot and a conical screw within the slotted aspect. The conical screw is tightened down, it widens out, and it clamps on the flange against the ring of the prosthesis, stabilizing it very precisely in a vertical way. So on this particular view, you could see in position 2 and 5, two template abutments embedded into the scan. In the clinical view, you'll see on position 2 and 5 the template abutments. You see the 3 anchor pins, and the additional implants are positioned, and we're then ready to disassemble the case. Template abutment 1 and a final implant in position. This case was done before the guided tissue punches were available. You can see that although the osteotomies are fairly clean and clear, there are some areas of soft tissue tags. It is critical that these tags are looked at and removed prior to the insertion of the prosthesis. If not, it will certainly hold up the seating of the prosthesis as you would have expected. So with very small surgery or laser, you can just trim the tissue away without any problem. The next step is the insertion of the guided abutments into the Procera implant bridge. The Procera implant bridge was created in advance with a precision milled titanium bar that's done with the Forte scanner at our lab partners, and they're able to create a milled bar that will fit precisely against the pre-positioned, pre-planned implant sites from the master model. You can have this in processed acrylic or in ceramic material. The guide abutments must be placed totally within the titanium sleeve of the framework all the way down, and then you bring it to the patient's mouth. Basically, using a two-handed technique, you secure the prosthesis into position, you push the guided abutments into place, and then start tightening them one at a time. And you don't want to go to complete tightening right away. Once it's stabilized, you can do some occlusal checking, perhaps some post-op x-rays to verify the fit and how precise we were with our planning. Then go back and do the appropriate tightening. We tighten on day 1 to 20 Newton centimeter and fill it with a material that's not like the occlusal aspect. So when we want to get back to do our final tightening several months later, we can just pluck that material out and then go to a final material at that point. So this is the way the patient looks approximately an hour after the surgery. So this is truly a teeth in an hour of a final titanium milled acrylic restoration, a final prosthesis hybrid design, if you will. Now again, just because it took us about an hour to do the surgical and the prosthetic aspects of the case, don't think it only takes 1 hour to do it. There was pre-planning, there was adjustment of the occlusion, there was the appropriate development of the duplicate denture, there was the gutta-percha insertion, all the steps necessary. So while we have a tremendous reduction at this point, all the pre-concepts that we know for ideal therapy are incorporated in this solution. The precision of the occlusion. Here are the marks the first time the patient is seated. We tap it out, and you can see uniformly there are marks on both sides. It may not be precise at both sides, but we just do a little bit of an adjustment with our restorative teammate, tighten it down, and I feel that this is quite precise for full arch restoration done in advance and at the time of the surgery. You can see the marks pretty clearly. Now, we're oftentimes asked, what are the prosthetic options? They're limitless. You can take the denture and put it back on if the bone is very soft and you want to have the implants submerged. You could go to a reline denture, you can go to a teeth in an hour as we just demonstrated, or we can go to an acrylic provisional. With an acrylic provisional, we could utilize the guided abutments, or we could use any other abutment system choice that we feel. A colleague may have a shell that gets filled up at the time of the surgery, and that still would be a tremendous reduction in time if they know in advance exactly where the implants are going to be positioned. Here's a case, the combination syndrome. Patient has a series of lower anterior teeth against a long-standing denture, and the ridge has been pounded over the years. There's the posterior mandible bone loss, and the bone is quite thin. My restorative teammate sent the case over, and our original thought was, can we do maybe 3 implants to help secure this maxillary prosthesis? Retention was the goal for this particular case. On the upper right, you could see the CAT scan that's been done, and you could see the little white dots. Those are the radiographic markers from the scanning prosthesis for this patient. This ridge truly is atrophic, clinically. Look at a higher view, you can see it's a significantly atrophic ridge. Now, you can do a lot of different therapies for this patient. Lateral onlays, vertical onlays, sinus grafts, and it's still going to be a thin ridge unless you have the graft working nicely. This patient was offered these options. They are very correct options. However, the patient did not want to go through that. So next step is, what could they have if we wanted to avoid doing these very sophisticated grafting procedures? So in the various planning software steps for the patient, we were able to note how thin the bone actually is. You can also see the little apical dot, and you can also see a yellow halo on some of these images. Wherever you see a yellow halo, the bone is dehisced. So it would allow me to move the implant more towards the area where there is actually bone. If we look at these 2 cross-sectional views, the implant on the lower left side is a 3.5 diameter implant that is actually positioned within the buccal and palatal aspect and below the sinus. So with the careful planning, we can identify sites that will allow for a small diameter or narrow diameter platform to be placed into the site. On the lower right screen, we're positioning the anchors, and it's very important to get the anchor positions within the flange of the prosthesis, not in the soft tissue space. If it's too much into the soft tissue space, when the guide is created, it will hang the guide up on the soft tissues. So a guide is created. This putty matrix is then made by my staff members, and we're ready to do the surgical aspect of the case. In our planning, remember I told you that the patient wanted to have 3 implants to secure the prosthesis. We were able to find 6 sites, all within the bone, even though they were narrow platform implants. As the previous case, the guide is positioned, the horizontal anchors are placed, and we start positioning on number 2 and number 5, vertical stabilizing template implants. On the upper left, you can see position 2 and 5 implants are engaged, the template abutments are placed, and the additional implants of the magenta or the 3.5 diameter are positioned into the site. You see a very minimal amount of surgical trauma, a little teeny bit of bleeding, and that is quite dramatic for a maxillary atrophic case like this, to be able to do a 6-implant surgery with just a few areas of blood dripping like that. Very, very comfortable for a patient. On the bottom, we see a panoramic view from the postoperative ICAT image. We see that we were not invading the nose, we were not invading the sinus, and the implants appear to be fairly well lined up. However, this is a two-dimensional view. It doesn't really show us the things that we really want to get out of the ICAT confirmation. So we start looking at the cross-sectional views, and we can see that the postoperative is almost identical to our pre-planned position of the implants. We can see the facial plate of bone, we can see the sinus, we can see the palate, and the implants are indeed within the confines of the bone. So we took a case where we were questioning whether we can have 3 implants to fasten the denture and position 6 implants, and now my teammate is going to create a full reconstruction on this patient, but because of the thinness of the bone, we chose not to load the case immediately, but instead we just did a denture reline for that patient and monitored the case for about 4 months. Now the implants are buried under the soft tissue. We then go to my restorative teammate's office with the guide. I place the guide in place with some local anesthetic, and using the tissue punch, I know exactly where the implants were positioned previously. So again, it's another minimally invasive procedure for the patient, and my colleague can then start the impression technique or reline it with the healing abutments in place and take the case accordingly. So there's tremendous flexibility and versatility with these methods. This is a case that we call a budget case, which is basically an all-acrylic restoration that can be done with processed acrylic at the laboratory level. It's less money for the team to incorporate because it does not involve the Procera bar. When done correctly, these all-acrylic restorations can last the patient up to 4 to 5 years. Now, at that point in time, you can convert the case. You can make a crown and bridge prosthesis. You can make a Procera implant bridge at any time. In fact, you don't even have to do any further impressions. You can just use the information that's already been established to create a Procera implant titanium frame bridge at any time. If you're doing this restoration modification, the surgical steps are exactly the same. You can see the surgical guide in place. The horizontal anchors are going to be utilized. Again, everything is starting to repeat. Positions 2 and 5, position the final implants, and the insertion of a fully acrylic restoration, and this patient had a very nice result for a fee that involved the implants, a guide preparation, the guide, and a very nominal fee for the laboratory aspects of this all-acrylic restoration. So it can be very affordable for some patients. This particular patient has an obvious facial lower face collapse due to severe atrophy in the mandibular arch. You can see clinically and the views of the prosthesis in place. These are some of the images from the planning with the prosthesis on and the prosthesis off. I was only able to position 4 implants in this anterior mandible. I normally would like to have 5, but due to the atrophy and the need for the precision placement of the anchors, I chose to do 4 implants into the site. These are some of the various views. And again, as I mentioned, you could put the prosthesis on, prosthesis off, and you could validate that the implants are not too close together, nor are the anchor pins too close together. In the lower right screen is what's called a transparency mode. You can actually click on a tool that allows the bone to go into a more transparent way, or more like a radiograph, and you could clearly see where the mental foramen and the nerve canal are. So for posterior mandible positionings, it's a very, very useful tool, and it allows for precision placement. Again, at higher power in the transparency mode, you could see where the mental foramen is, and the implant is positioned both mesial and lingual to the mental foramen. In the lower right screen, that would be the view from the right side, or the two-dimensional view, showing that particular site, allowing for the implant to be positioned. In the upper left, we see what we call a lab map. The lab map is a schematic of the case that we're doing that goes to our lab teammate So they will know exactly the length of the implants and the diameter of the implants that we plan to use. They have precision components that duplicate or replicate these and can set up the master model, and they know what's going on. We take this lab map and bring it to the surgery so our staff will know in which sequence, which length implants are going to be done. Many times the same diameter are done, but oftentimes we'll mix and match diameters, and therefore we don't want to get anything confused for the patient or our staff. This is the lower bridge done on the master model. You can see the 4 implants, and because of a metal framework in the Procera bridge, we're able to have a cantilever of a tooth and a half if we feel like it. Now, these are the surgical phases. It just kind of replicates itself, and the upper left shows the mounts going on to the canisters which house these sterile implants. You must get the mount down all the way. Because of the trilobe or an external hex, a mount may actually engage and clamp down without being seated. So it's a very important step to make sure that the implants are engaged properly against the mount itself. The mounts are then picked up and introduced through the guide, and the implants are placed as you see on the 2 bottom images. We again have a couple of little tags. We remove those tags. We insert the guided abutments to their fully depth, and we're ready to take it to the patient's mouth. It's put down, screwed down, and the patient goes through a series of taps, occlusal markings. You can see that there's a tremendous improvement in the lower face from the aesthetic aspects. But again, this slide now demonstrates the precision of the occlusion. We have some pretty strong marks on the lower right side of the screen. Across the anterior we have some markings and a minimum mark, but there are some markings on the other side in the molar region. So it's pretty uniform, but we're able to adjust the bite in an ideal way. We could take it off of the cantilever and adjust it a little bit more onto the vertical aspects of the prosthesis, where it's more supported by the implants directly. So we feel that these uses of CAD/CAM technology, three-dimensional planning software, working with the internet, is allowing our patients to actually use a new tool and some new technologies for our case. We've tried to underscore the surgical advantages, precision in planning, precision placement. If you have a thin ridge and you're going through with the guide, you're going to go right through in the ideal site. If you're taking a thin ridge without a guide, the drill could perhaps chatter or wobble around. This eliminates that. The amount of time involved in the surgery is dramatically reduced. We're doing flapless approaches. You saw several cases where there was almost no bleeding for the patient. The postoperative consequences are almost not known or seen by any of our patients. It's very, very comfortable for the patient, so there are tremendous surgical advantages. The efficient utilization of a laboratory colleague. Most of the prosthetics is done before we even start the surgical aspect of the case. So when we go to do the surgery, the prosthesis is done, we're ready to insert it, and it could take less than a half hour of time to insert the prosthesis because all of it was done by the Forte scanner, the titanium milled bars, and the addition of the acrylic or the ceramic teeth. So there's tremendous benefit using our laboratory colleagues. I mentioned earlier there's a huge change in the prosthetic phase of the case. If you're a restorative colleague and you're able to sit down at a surgical operatory, place the case into the site, push the abutments down, start screwing them in, do some occlusal adjustments and bites, and you're done, that's a tremendous advantage for you in terms of chair time. The patients are appreciative. They don't have 5, 6, 7 appointments. The amount of time involved is tremendously diminished. So while teeth in an hour can take place in an hour, as I mentioned earlier, there's a lot of steps that go through beforehand, and a lot of it is not done at the chair. So you can do this at home, you can do it with your teammates at lunchtime, planning the cases precisely, verifying the cases precisely, and then actually delivering it with a minimum amount of effort for the patient. So I believe that computer-guided surgery is the future, it is here, and the future is now. So thank you for your attention, and there are several training courses that we do in our practice. There are several other certified trainers around the United States, several in other countries as well, and I'll tell you that the software is actually pretty straightforward and easy to use once you start using it. But the biggest glitch is to learn how to use it. Don't get nervous if you miss a step, just go back. It's an easy software to go back and forth. And by working with it, there are Procera trained specialists that can help with the software training. And there's actually some courses that are being developed that are for colleagues that have taken courses that want an update on the software application, and it works out quite nicely. I'd like to say that one area where we're spending a lot of time is the partially edentulous case. When we first started doing osseointegration, you may recall that the cases were more ideally done on totally edentulous jaws. The hardware and the thought processes were created for those type of patients. Just like in this methodology, most of the cases are being done on totally edentulous jaws. Now, if a patient presents with a 2 or 3 tooth gap, I may do what's called a model-based guide, allowing me to use the guide components but not necessarily require the computer planning. If we have a hemi-mandible or hemi-maxilla where there's 4, 5, 6, 8, 10 teeth missing, we would then want to use the guide. There are certain aspects of the pre-prosthetic phase that are critically important. You want to have a scanning device that has a well-extended flange to allow for the markers, and the flange is going to come through in the planning software, and we're going to use that in the anchoring pin aspect of the case. So the flange development is important. You want to also extend it back to a tuberosity or to a retromolar area if you're doing a lower jaw to make sure that there's good stability. The different components have minimum requirements of thickness of the resin, so you don't want to have an implant positioned right at the end of a scanning prosthesis, because at the time of insertion of the implant, it may cause a craze or a fracture in the resin material. So you need an abundant amount of resin beyond where you position a distal-most implant. The other issue with partially edentulous cases is what's called radiographic scatter. This has nothing specifically to do with the Procera software. It has to do with what takes place with the radiographic images. It will take place on any scanner, and it's there. There are tools within this software that allow us to crop out the areas of the scatter, and oftentimes they're at the occlusal aspect of the case. So we're at the level of the bone and the soft tissue, so we could actually crop it down, eliminate the scatter, and proceed in a much more comfortable way. If you keep on taking the scatter along with you, it's just a nuisance. It doesn't prohibit doing the case. Couple of other tips. You want to have no metal as a plate or platform for the denture as it's being scanned. You want to prop it up on foam or styrofoam. And I have seen some colleagues put it on a Dixie cup, and the hard plastic rim of a Dixie cup actually came through the scan and was an interference. So you don't want to put it on a Dixie cup. You want it on a foam or a styrofoam type of apparatus. Again, if you're interested in this methodology, Noble Biocare runs courses through their own centers, through certified trainers like myself, and we're all too happy to help you out and get things going. In addition, there are specific Procera training personnel that are both conversant with the laboratory aspects of the CAD/CAM technology and the software. So it's truly exciting. It brings together the team as we've never been together. It allows for a variety of patient solutions, and we're minimizing chair time and getting a lot of fun and benefit to our patients and to our practices. So thank you for your attention. I hope you enjoyed this information.